welcome to the Department of Internal Medicine Grand Rounds. Before I introduce our speaker and topic, just a couple of quick housekeeping items. Next week, you'll be receiving a survey about some feedback on our current Grand Rounds as we plan for next season. So please be on the lookout for that and welcome any opportunities to improve things. Couple of housekeeping things. We are still virtual for the remainder of this year, hopefully starting with a hybrid approach in September when we return. There will be a Q&A session at the end, the last 5 minutes of this session. The CME code will be posted in the chat now, and then again at the end of the session for you to record and get CE credits. We will also record the session and it will be available on the website. Thank you all, we appreciate it. Today's Grand Round session is sponsored by the Division of Nephrology here at VCU. The title of the talk is Viral Infections in the Deceased Kidney Donor, Hepatitis C, HIV, and COVID. Are they safe to transplant? Our speaker today is Dr. Gaurav Gupta. He's the Associate Professor of Medicine and Surgery and Vice Chair for the Division of Nephrology. He's also the Medical Director of the Kidney and Pancreas Transplantation in the Department of Internal Medicine here at VCU in Richmond, Virginia. Dr. Gupta received his medical degree from the All India Institute of Medical Sciences, the premier medical school in India. He completed his internal medicine residency training at the University of Pittsburgh and a nephrology fellowship before finally completing a transplant nephrology fellowship at Johns Hopkins in 2012. He joined VCU in August of 2012 and promoted to associate professor in 2017. He then became the medical director of kidney transplantation here at VCU in 2018 and received an affiliate position as an associate professor of surgery with the Department of Surgery, as well as the vice chair of the Division of Nephrology in 2020. His current research focuses on increasing access to kidney transplant and molecular diagnostics in kidney transplants. He's an international leader and pioneered the use of hepatitis C positive donor organs for hepatitis C naive kidney transplant recipients. In addition, he's an international expert on the use of molecular diagnostics in kidney transplants. He's published more than 70 peer-reviewed publications and serves on the editorial board and as a reviewer for multiple journals. He also serves as principal investigator or co-principal investigator on several industry-sponsored, investigator-initiated, and NIH-funded studies. He has served on multiple national committees, including those for the United Network of Organ Sharing, UNOS, and the American Society of Transplantation. Dr. Gupta, thank you for taking time and joining and sharing your passion with us. We look forward to hearing your talk. Thank you.
Thank you to Dr. Bergman and the Department of Medicine for the invitation. Let me just start my slides. Christian, just to let you, are the slides visible and appropriate? Thank you. Well, good afternoon, everybody. So I'll be talking about deceased donor kidney infections, including hepatitis C, HIV, and COVID today. We've been working on these areas for several years, so I'll be sharing a lot of our own research as well as other content from other research groups. These are my disclosures. Relevant to this talk are research funding from Gilead and the VCU Presidential Research Quest Fund. So the first objective of this talk is to recognize the discrepancy between supply and demand of kidney transplants. So if you look at this slide, what it shows you that the differences in expected remaining lifetime between the end-stage kidney disease population and general populations is very striking. Dialysis patients younger than 80 years are expected to live less than a third compared to their counterparts without end-stage kidney disease. And transplant patients fare much better than that, with expected remaining lifetimes for people under the age of 75 at around 68 to 80% of expected lifetimes in the general population. So based upon this data, we've known for several decades now that transplant is the treatment of choice for patients with kidney disease with regards to prolonged survival and quality of life. The problem is that there is a huge discrepancy between those who need transplants versus those who can get transplants. And what you see here on the slide in the dark blue line is the number of dialysis patients over several decades. And you can see that numbers have gone up over several decades, although they seem to be flattening out somewhat right now. But the transplant rates really have remained flat with no real increase, although that may have changed slightly. Nevertheless, there is a huge gap between patients on dialysis versus patients who are getting transplanted. And you can see the same here on this slide, where transplants rates lag behind substantially with regards to waitlist additions for those who need a transplant. What is also noticeable and somewhat surprising is that there is a flattening out of the waitlist addition, and that has also become a new source of research and concern. And people have been looking at why this may be so. So it seems like both addition to the waitlist and transplant rates have slowed. And this paper looks at the barriers to transplant. And a few things stand out here. What you'll notice is that being a Black American, having a lower income, and health literacy are all associated with lower rates of transplant. And we here at VCU at Kidney Transplant take pride in being able to enhance access to these populations. And I'll show you our numbers at the end of this presentation. So moving on to the next part of this talk, which is the lion's share of the rest of the time, and to understand the data that supports safe utilization of donors with viral infections. And I'll first focus on hepatitis C. So what this slide demonstrates is the impact of the opioid epidemic in the US on the organ supply. And you may want to call this a silver lining of the unfortunate opioid epidemic. In the top left corner, you'll see that the availability of potential donors rose rapidly upwards as overdose deaths went up over the last several years. A majority of those donors, not surprisingly, are hepatitis C positive, primarily because of needle sharing practices. And you can see that at the top right corner of the slide. And this is true for all organs, which you can see at the top left, at the bottom left, but much more so for the kidney transplant world in the bold black line, which shows a rapid upward trajectory beyond 2012. As an example, nearly 3,500 transplants were performed using overdose organs in 2016, compared to just 150 in 2000. But the problem with this practice has been that before the arrival of the direct-acting antiviral drugs, we did not have effective therapies for hepatitis C. So in the era from 2005 to 2014, these authors looked at the kidney discard rate from donors with hepatitis C. And they found that nearly 3,000 donors were approached, and of those 6,500 kidneys that were procured, a large majority were discarded, nearly half of those. And that translated into 500 extra kidney discards every year over a period of 10 years from 2005 to 2014. And these kidneys could have been used for those with or without hepatitis C for transplant if we had the right ways to do transplants safely for those patients. And that's kind of the genesis of this these research papers, which I'll share with you, including our own data. So very briefly, purely for as a brief overview, this is a natural history of hepatitis C. And what you see is that when an immunocompetent patient gets infection with Hep C, up to 50% could have spontaneous clearance. And these people will have a Hep C antibody positive seroconversion, but their PCR or nucleic acid test or NAT will remain negative, and they are not considered infectious in the context of organ transplantation. But the other half, or up to 80%, will develop a chronic infection, which can then result in many different pathways, including stable infection, slow progression, or rapid progression. And these patients will have a NAT positive as well as antibody positive result on their blood tests. And these, of course, would considered be infectious almost 100% of the time. So if an organ from this donor were to be used, they would transmit the infection to the recipient. And with regards to how much time it takes for these tests to turn positive, for a net positive test, it takes very short time, within 5 days of the initial infection. Seroconversion with antibody positive takes, of course, longer, with between 2 to 6 months after the initial infection. So, of course, as I'm sure all of us know now, that there's been a revolution in Hep C therapy with over the last 10 years, and you can see that there are now drugs which will target all genotypes of hepatitis C. And the commonest drugs that are used for these indications now are at the top here, Eclusa, and then Mavorix and Vosevi, which is the most recent addition to the repertoire of DAs. The problem in the elephant in the room with these drugs is the cost of therapy. And although this is a somewhat older paper, you can see that the cost of treating a single patient with hepatitis C ranges anywhere from $15,000 to more than $200,000. At the current time, the numbers are close to $30,000 per patient with a 12-week course of direct-acting antivirals. So that remains a real concern when we think about translating these into real practice. When we give a patient who does not have Hep C a kidney from a donor with Hep C, and then you have to treat the patient with $30,000 worth of drugs, which require insurance coverage, that can be a problem. But is it feasible? And that was done with these three trials, which I'm going to share very briefly. The first from UPenn, the second from Hopkins, and the third was ours. So in this initial trial from UPenn, only 10 patients were enrolled. And they looked at only genotype 1 because the drug they had at the time was only effective against genotype 1. And they found that 10 of those 10 recipients achieved a cure with 12 weeks of therapy after transplant. The next trial, called Expander 1 from Hopkins, was very similar. Once again, 10 patients were enrolled and again treated for the full course with sustained virologic remission or cure after therapy. The interesting part about this trial was that even by week 1 of initiating therapy, they were all virus negative. And this data was the trigger for our own trial design, which I'll show you in a few moments, with using a very short course of prophylaxis as opposed to 12 weeks of therapy. And the reason why we felt that prophylaxis, the short course, would be appropriate as opposed to trying to treat the patient after they get the infection post-transplant with insurance approval was because of this data that was well recognized at the time, that a large majority of patients with different insurances could get denial of direct-acting antiviral therapy in time, and that may result in delay in therapy, or worse, not even adequate therapy. And because of that worry, we felt that if we could eradicate the infection early on, we may not have to try to get full treatment for every patient with a kidney transplant. And that was corroborated by the real-world experience that was published over the last 3 or 4 years. So this was experience at the Cleveland Clinic in Florida, where they found that there was a delay in therapy from initiation of transplant to Hep C infection and then followed by therapy. And in that period, they reported 2 patients who developed fibrosing cholestatic hepatitis, which can be acute and can be fulminant. And therefore, there was a concern that this delay in therapy may not be appropriate for immunosuppressed patients who may be at a high risk of developing these complications compared to immunocompetent patients who get acute Hep C. Another paper also showed similar problems. It took at least 8 weeks after transplant to get insurance approval for these drugs. Around 20% of the patients developed antibody against their donor, and around 20% also had abnormal LFTs or liver function tests while waiting for therapy. So in that context, our trial design becomes even more relevant. And I'll show that to you here. And this was, we call this the DAPA trial. And the hypothesis was, can shorter courses of DAA prophylaxis eliminate or minimize Hep C transmission? And this was published in 2019. We designed this in 2 phases early on with a very, very cautious approach of enrolling 3 patients at a time. And then over time, expanding that to a total of 25 patients. In the first phase, we enrolled only those who were either above the age of 60 or had comorbidities, which would predict worse mortality on the wait list without a transplant. We had a data safety monitoring board, which was used to monitor our data prospectively. We used a total of 3 days of prophylaxis, meaning first dose before transplant and just 2 doses after that, so post-transplant, with the hope that that may be adequate to prevent transmission. And then based upon those results, we went onto a phase 2, which is on the right, where we did 4 doses of prophylaxis with 15 patients. Since then, we have expanded that protocol to 7 days of prophylaxis. And this is the most recent data published last year, where we've opened this to almost our entire wait list. In this prospective registry study now, we looked at around 400 patients. Of those, 80% were eligible. Nearly half of those accepted Hep C positive kidneys, while the other half said no because of safety reasons. Of course, because there's an informed consent with all of the appropriate regulatory parameters built into these protocols. And what we reported was that of the patients who were willing to accept Hep C positive kidneys, 53% of those got transplants, while for patients who did not, only 43% got transplants within this time period. The point being that acceptance of Hep C positive kidneys can result in reduced wait time and thus, in theory, improve mortality in the long term. Our protocols for prophylaxis have evolved over time. In group 1, we used a drug called Zepatier. Pardon me. We used a drug called Epclusa, sofosbuvir or vilparasvir for treatment, and Zepatier for prophylaxis. In group 2, we've used Epclusa exclusively for prophylaxis, and in group 2B, we've continued to use Epclusa with its pangenotypic, but the difference is that we now use Mavorite or Lecapravir, Pibrentasvir for therapy for those who break through with infections. The first 2 studies, group 1 and group 2A, were based upon support by the VCU pharmacy and Gilead, but after that, it's been through patient insurance for those who break through. For prophylaxis for 7 days, it's done via the VCU kidney transplant program, and therefore there's no cost to the patient, and there is no delay in therapy. So looking at the viral transmission outcomes, so this is our initial trial. So first 10 patients, only 3 days of prophylaxis, and with that, we saw a 30% transmission rate. With group 1B, we used 4 days. With that, we saw a 10% transmission rate, bringing this total transmission to 7 of 52 or 13%. And then most recently, with 7 days of prophylaxis, the transmission is down to now 2 of 50, 4%. We actually have done nearly 175 transplants at this point with these protocols, and the transmission rate remains at 4% or so. Of these 7 patients at the top and the 2 patients at the bottom, total of 9 patients, all of these 9 patients have received a full course of direct-acting antivirals and have achieved a cure from Hep C at this point. So the next question was, how do these patients do compared to patients who received Hep C negative kidneys? And we looked at that here with a matched cohort of patients, where you can see controls, patients who got Hep C negative kidneys versus patients who got Hep C positive kidneys. And the demographics are fairly similar with one major difference. Patients who accepted Hep C positive kidneys had a lot lower wait time compared to patients who did not. And as a context, wait time pre-transplant, meaning dialysis time pre-transplant, is the most important predictor of outcomes after transplant. The longer the wait time, the worse the mortality post-transplant in a patient who receives kidneys. What about liver function? These patients continue to do well after their transplant with regards to liver function compared to the controls. We did not see any abnormal liver function in these patients compared to the previous studies, which I showed you, where up to 20% of patients had abnormal liver function studies. The reason, of course, is that only a very small minority of our patients developed Hep C, while a large majority, more than 90%, never acquired Hep C from their donor. Kidney function numbers, again, look very similar. Both cases and controls did very well up to 12 months of transplant in the study. And once again, what this shows is that there was no adverse impact of hepatitis C donor status on these patients. And then lastly, the most important part was about cost. So what we did was with the School of Pharmacy colleagues is to look at different protocols available. The one which is ours, 7 days of prophylaxis, plus therapy for those who break through. Our rate is 4%, but if we build a 95% confidence intervals around this data, the incidence could be anywhere from 0% or 13%, as opposed to 4 weeks of prophylaxis, which has also been published recently, as opposed to 8 weeks of treatment, which is now most recently published. So we looked at this cost analyses using different parameters, and what this data shows you is that if you use 7 days of prophylaxis, which is in the middle, the cost to the payers is around $3,000 total, as opposed to treating every patient who gets the infection from the donor, as opposed to prophylaxis, meaning no prophylaxis but full course DA at the top. The cost is around $26,000, so nearly 10 times more than our strategy. And then 4 weeks of prophylaxis, which results in a cost of around $6,000, meaning twice of what our strategy indicates. So to conclude this part of the talk, we have shown that 7-day prophylaxis is effective in preventing Hep C transmission in a large majority of up to 96% of patients, but not all transplants. We found a very low risk of de novo donor-specific antibody formation against the donor, which helps with graft outcomes and avoiding antibody-mediated rejection of the kidney. We found no cases of fibrosing cholestatic hepatitis, unlike the ones reported in the literature. And we found that 7-day prophylaxis is the most cost-effective to payers at current costs. So with that, I'm going to move on to the second part of the talk, which is using donors with HIV. So in the US, for those of the audience who may not be aware, up till 2013, the utilization of blood, tissue, and organs from HIV positive people was not allowed by federal law. This study from South Africa showed that kidney transplants from HIV positive donors to HIV positive recipients was possible and safe. And this was published in the New England Journal in 2010. And what the author showed was that a patient survival of 75% at 5 years and a death-censored graft survival of 84% at 5 years. And this spurred research into this area that this was theoretically possible using HIV positive donors for HIV positive recipients, because in theory, these patients would remain on treatment for the rest of their lives, and therefore they would not be susceptible to new infections as long as the resistance profiles from donors could be managed appropriately. So this set the stage for this paper, which was published from the Hopkins group in 2011. And what it showed was that they looked at the national death data, and then they looked at amongst those deaths, how many were from HIV positive people, and amongst those, how many may qualify for donation based upon established national criteria. And they estimated that for amongst those donors, up to 60 kidney donors and up to 220 liver donors could be identified, resulting in 250 extra kidney or liver transplants every year. And What happened after that was very impressive, and a lot of lobbying was done by the transplant community to the US Congress and led to the passage of this act called the HIV Organ Policy Equity Act, or HOPE Act, that allowed for the utilization of the HIV positive organs. It was passed in 2013, and it was only one of the 50 some acts passed that year, so a pretty strong work from the transplant community. The one caveat of this act was that the law mandated that these transplants should be done under an IRB-approved investigation protocol and under the auspices of UNOS, United Network of Organ Sharing. So VW protocol here at VCU, initially it was done with the help of Dr. Tara Cruz with Transplant ID, and Dr. Dan Nixon and Dr. Patricia Fulco. Now we have our newer ID colleagues, Dr. Morales and Dr. Bisicelli, partnering with us on this. So we also contribute our own data into the National Registry for this. And the first paper from this registry was published in the last 1.5 years or so. And we have some of our own data from VCU in this cohort. And the authors identified over a period of 3 years, 14 centers who had done these transplants. Of these, 75 patients who were HIV positive received kidney transplants. So 25 were donor positive, meaning 25 received kidneys from true HIV positive donors, and 50 received kidneys from HIV negative donors, which was the standard of care before anyway. And they compared the outcomes of these patients who received HIV positive versus HIV negative kidneys. And you can see that graph on the left, where you see that the graft survival at up to 3 years of transplant was no different between the three groups. They did not find an increased risk of infections also in this comparison. The concern, of course, was HIV-associated infections could be transferred, like Cryptococcus, etc. They also did not notice any HIV drug resistance, which evolved into the recipient from the donor. They did report on the fact that some of the medications for HIV recipients had to be changed based upon donor profiles, but none developed resistance, and none developed HIV illnesses or frank AIDS illness. So this supported the concept that these transplants are safe, at least in the intermediate term of follow-up. One very interesting aspect of this work was the identification of HIV false positive donors. It was found that of the 35 donors identified as HIV positive by the initial testing, either by a PCR, which is a qualitative nucleic acid test, or by an initial antibody test, 10 were found to be false positive after repeat testing, with confirmation by Western blot or by a quantitative PCR. And these are 4th-generation assays that were used here. And the authors estimated that based upon these false positive rates of 10 of 35, an additional 50 to 100 kidney transplants could be had from these false positive donors. And of course, they would have been discarded in the pre-HOPE Act era, because once you have an initial positive, this would have shut down that particular donor case for every transplant. So this was a blessing in disguise from this HOPE Act. There are many other studies going on right now, which we are a part of, and I hope to share that data with you in the next several years. So moving on to the SARS coronavirus 2 or COVID-19. So that's been a very recent evolution, of course, as you can imagine. So of course, the first question and the first step in the utilization of organs with COVID has to be to figure out whether there is a risk of donor transmission or not. Since COVID is primarily a respiratory virus, the likelihood of transmission through abdominal organs like the liver and the kidney would probably be low. And that was shown by many early studies, like the one I show you here from JAMA in 2020, that showed that COVID was not detected in the urine from patients even with severe COVID. And you can see that in these dark blue diamonds, which are at the bottom, what you're seeing on the y-axis is cycle threshold, meaning how many times does it take the virus to be amplified on the PCR? And I'll share some data about this in the next few slides. But the point is that the higher the threshold, the less it is likely that this is true virus. So you can see that all of these diamonds are below a cycle threshold of, are above a cycle threshold of 40, meaning that there is almost no virus being amplified from the urine. There were other biopsy studies from autopsied kidney tissue early on, and apart from initially one or two, none of those studies showed any virus from the kidney tissue. So one criticism of these biopsy studies was that the methods to detect virus in the kidney in early 2020 were not advanced enough. And that has kind of spurred additional research in this area, which I'll share in the next few slides. So having said that, the dogma by the middle of 2021 was that the virus does not affect the kidney, and therefore these organs could be utilized. That was challenged recently by these two papers. The first one is projected here. And what these authors from the Veterans Administration, the VA population looked at was pretty interesting. What they did was they compared patients who did not have a diagnosis of COVID, meaning they never had a positive COVID NAT test in the VA database. And they compared those patients to anybody who had a positive test, be it they were non-hospitalized or be it that they were hospitalized with or without acute kidney injury. And they found that patients with any diagnosis of COVID had a negative loss of GFR over time, as compared to patients who never had a diagnosis of COVID. And you can see that here that the non-hospitalized patients had a net loss of GFR of around 2, patients who were hospitalized without AKI of around 4, and patients with AKI of around 6 to 8 net loss of GFR in mLs per minute. And based upon this, the authors suggested that there may be a direct impact of COVID on the kidney, although of course they admitted that this could be due to hemodynamic alterations like hypertension resulting in chronic kidney disease in the long term. So further data has come from this paper that was just published in the last 2 months in Cell. And the authors used advanced staining methods to show that SARS-CoV-2 is present in the autopsied kidney tissue from patients that died due to severe COVID-19. And you can see that in the panel C and D with the arrows, where the viral nucleocapsid protein is stained red in the perinuclear parts of the cell. They also showed in the panel G that it co-localizes with real proteins like ACE2, which is a well-known receptor for SARS-CoV-2. So based upon this, the authors suggest that SARS-CoV-2 does directly infect kidney tissue. And then they went on to look at the next steps, which are shown in the bottom panels, where they looked at injury biomarkers like KIM1, which is kidney injury molecule 1, and NKCC2, which is profibrotic, as well as collagen, which is seen in J and K panels. And what they hypothesized and based upon these data is that SARS-CoV-2 may promote injury and may promote fibrosis in the kidney. And that may be the reason for the data seen from the last study, which I showed you, where there was a loss of GFR over time in patients with SARS-CoV-2. So this has led to a rekindling about this conversation whether the virus could be transmitted to kidney transplants, although of course that data does not exist as of now. So one problem with the current practice is that the way we detect virus is via nasopharyngeal swabs. And this paper shows that as patients move further away from transplant, the quantitative viral load goes down over time. And you can see that in this panel, which I highlight here, where as the patient moves away from the initial diagnosis, the viral load is going down and the rate of positivity is going down. Nevertheless, you can have patients who are positive up to 20 days of the initial infection, even in the immunocompetent world. For transplants, this is much worse. Our patients have been known to shed for several months after initial infection, despite being asymptomatic. Now, the argument against this being a true infection comes from this second panel, which I highlight now, which is that if you try to grow this virus in culture, a majority of samples taken after 8 days are negative by culture, with the argument being that this is probably not infectious virus. And in this third panel, you can see how a high log value by quantitative PCR correlates strongly with a positive viral culture, indicating that the more the virus, the more the likelihood that it is going to grow in culture, and the more the likelihood that it's going to be infectious. Now, unfortunately, that's not how we actually do testing in real life practice, where we only do qualitative PCRs, like we see here, where we report out a positive or a negative test. So one way to measure how much virus is being amplified in qualitative PCRs is via cycle threshold, which I showed you in the last few slides. And that's been called CT for short. And what CT can tell us as to how many times does the virus need to be amplified to be detected in a PCR cycle. And what that means is that the lower the CT threshold, the more the viral load. And the higher the CT threshold, the less the viral load. Now, in theory, that makes sense, but in practice, there are a lot of problems with that assay. And based upon the summary of the data published so far, which I cannot present for the sake of time, the IDSA has put out the statement, and what they describe is that CT threshold should not be considered a quantitative measure of viral load due to a myriad of analytic and clinical factors, and it should also not be considered as a predictor of active infection and hence transmissibility. At the current time, routine use of CT values to inform clinical decision-making is not advised. Now, having said all that, from the beginning, transplant professionals like myself and ID professionals like my colleagues have been using CT thresholds to determine whether a donor could be infectious or not. And we at VCU determined the threshold 32 as the optimal one based upon the review of literature, although that again now remains debatable based upon this statement. So with that background, the question is there a pool of donors with SARS-CoV-2 infection? Now, this is the CDC data from yesterday, and you can see as of yesterday, there have been nearly 1 million deaths from COVID in the United States. And it stands to reason that at least some of those would be potential donors, if not for COVID. So we looked at that recently, and this was published in the last month or so. And we looked at the National UNOS Registry for donors who were COVID net positive at the time of organ procurement. As background, every donor at the current time, from every deceased donor at the current time who goes for organ procurement has to undergo COVID net testing before organs are procured. Whether it's positive or negative is a secondary matter with regards to organ procurement, but the testing is done primarily to ensure that the staff which goes for procurement knows what they have to deal with regards to PPE requirements. So we looked at this national landscape of COVID disease donors since the beginning of the pandemic, March 2020, till the end of September 2021 in this paper. And we found that during this time period, nearly 17,000 deceased donors with negative COVID net or PCR and 150 with COVID net positive were assessed for organ donation. And what this graph shows you in the blue is the number of COVID net negative organs that were transplanted at the top. The second is number of COVID net negative organs that were recovered but not transplanted, and at the bottom, organs not recovered at all. In the orange bars, you see the same distribution of COVID net positive organs. And the summary of this slide is that when compared to COVID net negative donors, there was a much higher likelihood of organ discards for COVID net positive organs. For hearts, it was 35% versus 87%. for lungs, around 70% versus 100%. For livers, 24 versus 50%, and pancreas, close to 99% of organ discards for COVID positive donors. So essentially, the message is that a large number of COVID positive organs were discarded even after being procured. Of course, this is just the tip of the iceberg because a large number of COVID positive organs were never recovered and never procured, and we estimate that based upon the death rates from COVID in the country. So when we look at the donor characteristics for those 150 donors, we see that a total of 385 recovered organs were done from these donors, and nearly 70% of these organs were transplanted into nearly 260 recipients. The donor details are what are presented here. And the interesting part which I want to point out to you here is that a majority of nearly 50% actually had a pulmonary infection based upon imaging. Unfortunately, the problem here is that this is national registry data, and we do not have any further details about what findings were present in these donors with regards to COVID and how severe their disease was. So what about recipients who received these organs? So again, we have very, very short follow-up for these patients of no more than 30 to 90 days at the time this paper came out. What you'll see at the top is a majority of them were kidney transplants, 180, with 50 being livers, and the others mostly being multi-organ transplants. And the big point, though, is only 5 deaths were reported in this initial 90-day period, 2 for kidneys and 3 for livers. None of these were ascribed to COVID pneumonia based upon the analyses, but keep in mind that additional details are rarely available. And that's kind of why we need more granular data from single center studies, which can kind of provide more details about what's going on with these patients. So the first and only paper about this came from the Cleveland Clinic, where they used 5 donors and 10 kidneys were transplanted from these 5 donors. And what I want to show you here is highlighted in the red, which is that all of these donors had an incidental COVID positive test, as opposed to having COVID as the primary cause of death. So with that context, we have designed our own study, which we're collecting data from right now. So this is a prospective IRB approved registry. Our approach is to ask a patient to provide informed consent, which is approved by risk management. We approach only vaccinated recipients for these kidneys. In consultation with ID, we have used remdesivir prophylaxis, although the value of this may or may not be useful, but that's what we're doing at the current time to avoid any remote risk of COVID transmission. Given the data I showed you earlier about the possible infection of the virus in the kidney, we are collecting both donor blood and donor kidney tissue to amplify the virus in the future. These samples are currently being banked. The PCR will be done at an outside facility, probably the next 5 to 7 days. At this point, we have 25 organs, 24 kidneys, and 1 liver. We also do a COVID plasma and a nasopharyngeal swab at 7 days post-transplant. And of course, serial monitoring for symptoms and graft measures. So these are the donor data for these 24 donors. And the big thing which I kind of want to show you is with regards to donor COVID symptoms and donor COVID diagnosis, which is here in the 4th row from the top. You can see that unlike the Cleveland Clinic paper where nobody had a primary diagnosis of COVID, in our cohort, 35% of the donors did have COVID as a primary diagnosis for admission. And nearly half of these had some symptoms concerning for COVID, with 60% of them having findings on radiology considered typical for COVID. And this is somewhat similar to the national data which I showed you earlier. What about recipients? So we have 25 recipients so far. For the first 7 days of transplant, we do a nasopharyngeal swab as well as a serum PCR. Nobody has had a positive test in the first 7 days, indicating a lack of early donor transmission. 3 patients turned COVID positive between 3 to 4 weeks of transplant. And that's seen in the second row from the top. all three were diagnosed in January at the height of the Omicron surge in 2022, and two of those had known sick contacts in family after discharge from the hospital. We believe that these are community acquired rather than donor acquired. Unfortunately, we tried to reach out to donor centers to obtain samples from the donor swabs for genomic analyses, but we were unable to obtain them because they had been discarded very quickly. So we cannot prove that these were definitely not donor acquired, but rather community acquired from our data. Although all of our patients are currently doing well and there have been no graft losses or deaths. The 3 patients who did get COVID who were treated, 2 with sotrovimab monoclonal antibody, and all 3 got remdesivir and have no residual sequelae of COVID at the current time of follow-up. So I did mention the donor tissue that we've collected, and all of those studies are still pending as of now. So with that, I'm going to end with this last slide, which I'm particularly proud of. This is the growth of the kidney transplant program at VCU over the last several years. And this was done despite the pandemic. And what I would really like to highlight is our success with the socioeconomically disadvantaged populations like Black Americans. 2/3 of the disease on the kidneys here at VCU have been performed in those populations, which is the 3rd highest in the US by volume. And with that, I'm going to end this presentation. I have to thank a lot of collaborators, partners, nurses, patients who've helped us do these studies. And I'll stop here, and questions are welcome. Thank you.
Wonderful. Thank you, Dr. Gupta, and wonderful work. Congratulations on that last slide. And, look forward to hearing more updates in the future. Any questions from the audience? I have a couple of questions. I was wondering if you can go back to the beginning. There was a slide on social factors and access to transplants. It was from the clinical journal from the Society of Nephrology, I think. And I just had a follow-up question in regards to that. Do you know, obviously expanding access to the pool itself would help, but, are there, does it tie directly into ongoing efforts to address all of the 10 factors on the right side? Is there anything specific with the this particular donor pool or recipient pool that you think is impactful? Do you have any further comments on this slide?
Yeah, so thank you for the question. So we have collaborations with groups in psychology at the University of Richmond, as well as with VCU, the Uptown campus, to try to focus on the socioeconomic factors as well as frailty, because both of those are impactful with regards to access to transplant. The biggest thing that we've done with the utilization of these particular organs is health literacy. So we spend a lot of time in the program in educating our patients when they come home for transplant. So just like the transplant rate, which I showed you, similar to that, 2/3 of our wait list is also African American populations. So our transplant rates are very equally distributed based upon our wait list, and which kind of highlights that our education efforts, which are focused on patient education via videos, via brochures, via direct face-to-face contact with physicians, as well as nurses and psychologists, have yielded the benefits that I show you with regards to ensuring that our transplant rates in these minority populations remain equally good for these high-risk organs, which in theory could be impacted because of the lack of health literacy.
Thank you so much. Appreciate it. Thanks for highlighting this. Really appreciate it. Any other questions from the audience? I have one in the chat box here from Dr. Stephanie Meyer. How have COVID infections affected patients living with transplants on immunosuppression? Have they have higher rates of COVID infection in general, maybe from requiring more healthcare appointments? Has it affected graft rejection or rates of survival?
So yeah, I think we can all agree that COVID has had a substantial impact on transplant patients at VCU. For those of us who do inpatient service, it's been a profound and unfortunate last 2 or 3 years. There is an increased risk of mortality and hospitalization when immunosuppressed transplant patients get COVID. Many of them end up in the ICU. The rates of infections are probably similar, but the rate of hospitalization and mortality is higher. It's estimated to be between 10 or 20% mortality compared to 2% of the general population, so nearly 10 to 20 times more. So does more healthcare appointments impact that? I don't think so. We know, to be frank. We did have, excuse me, have a very, very small outbreak of COVID amongst inpatients at one point, but that's not being repeated, which was acquired in the hospital. We have had a very good system with regards to staff to ensure that masking is done well, hygiene is performed, and then anybody who may have symptoms is triaged to not come to work and screened at the appropriate employee health locations. So I would say that the chance that frequent healthcare appointments resulted in more COVID would be less likely. But again, I cannot prove that one way or the other without significant contact tracing, which we have never done. Has it affected graft rejection rates? So graft rejection wise, we do not have any signals, and we have published on this topic, that there has been an increased risk of graft rejection because of COVID infections or because of the pandemic in general. Survival, as I mentioned, yes, it has been impacted. The mortality of our patients has been higher, much higher compared to other populations. The things we have done recently and over the last year or so to kind of impact that is to really be very, very aggressive with vaccination with multiple doses. As the science continues to evolve, we've been keeping up with this with CDC guidelines with 3, 4, and now up to 5 doses. There's a prophylactic monoclonal antibody called Evusheld that some of you may know about. It is a combination of 2 monoclonal antibodies, which may provide prophylaxis and protection against COVID for up to 6 to 9 months. We've partnered aggressively with both ID epidemiology as well as the VA Department of Health to provide those prophylactic doses to as many patients as we can in the clinic. We don't know whether that's going to help in the long term or not because the drug just came out the last 2 or 3 months. But that has been kind of our stance to provide this to as many people as possible to potentially reduce those COVID cases and hospitalizations moving forward.
Thank you. Appreciate that. Any other questions from the audience? You can ask to be unmuted if you want to ask live or use the chat function. Okay. Any words for us? Any words of wisdom or things that we can help you all with from the Department of Medicine?
I think I do want to thank all of the providers who really helped us take care of these complex patients over the last 3 years, particularly the intensivists and the ICU staff. It's been a slog for all of us, so I do appreciate that, and I do appreciate the camaraderie, which I've seen in the groups internal medicine. So thank you for that. But beyond that, I think we do need to keep communicating, keep talking to ensure that we do the best that we can for these patients.
Thank you so much for your time today, Dr. Gupta. We appreciate the presentation and good discussion. Thank you. For everybody, the CME code will be in the chat box here again. And again, the lecture should be recorded and will be posted on the website in about 1 to 2 weeks. Thank you all for everything. And we hope to see you all in person soon. Thank you all. Have a great, wonderful rest of the afternoon. Thank you, Dr. Gupta.
Thank you.